Hello, I am Patrik Michel in Lausanne, Switzerland. Thank you, Professor Mir, for this kind introduction. I'm happy that we can discuss the challenging topic of posterior fossa strokes together, and I will be talking about the general features of this kind of strokes. Let me just share my screen. So when we have to detect brainstem strokes, it is a true challenge. I myself have missed a few posterior circulation strokes in the last few years. I have other conflicts of interest, research grants, consulting fees, and steering committee of the basilar artery occlusion randomized trial. You will ask whether it really matters whether we diagnose posterior fossa strokes correctly. And of course it matters, because these strokes are more often missed clinically and radiologically than other strokes, and therefore we miss the opportunity to do thrombolysis thrombectomy. And if we don't do this, they will have a worse outcome. Secondly, we underestimate usually the impact of posterior fossa strokes, but despite the disabling deficit, we may not thrombolyze them, or we may not send them to rehabilitation. And we also do the opposite. We may overtreat such patients, because if we don't diagnose a hemi syndrome correctly as being, for example, a pontine lacune, we will do a thrombectomy, a carotid endarterectomy on a patient with an asymptomatic carotid stenosis. So it really matters that we diagnose this correctly. Now, this is maybe the most important slide, where we show the differences between anterior and posterior circulation strokes. As you can see here, these are a comparison of 1,500 stroke patients, and you can see that the main distinguishing features, as you probably guessed, were cerebellar and vestibular symptoms and sign in posterior fossa, oculomotor brainstem signs, and we will discuss those in more detail, and decreased level of consciousness. Also, something which was not measured in this study, of course, bilateral and crossed manifestations are more common in posterior fossa strokes. You may also notice that dysarthria is actually not more frequent in posterior fossa strokes, despite what people often think. Now, if we go to the menu, we will be talking about acute vestibular syndromes, oculomotor problems, level of consciousness, and bilateral and crossed manifestations. So when it comes to acute vestibular syndrome, acute vertigo, you all know the big challenge. Is the vertigo due to stroke? And the good news is that even based on the telephone history that you can take, you already have several red flags that may indicate to you this kind of strokes. If the onset of vertigo is acute and spontaneous, this is maybe stroke. If the patient cannot walk anymore or sit up, even with help, then it's probably a stroke. If there is an associated hearing loss, unusual or new headache, or a patient with a lot of vascular risk factor, you also consider those strokes until proven otherwise. And of course, you will look for other neurological symptoms and signs. And for this, we have the helpful 4Ds and 4Hs. So if you have diplopia, dysphagia, dysarthria, dysphonia, or one of the 4Hs, hiccup, a Horner syndrome, hypertropia of one eye or the other, a hemi syndrome, even a mild one, then you will consider this stroke. Now, when the patient is in front of you, you will examine him or her, and you will look for subtle neurological signs which may indicate stroke to you for acute vertigo. Again, you look for the 4Ds and the 4Hs on examination, such as a Horner syndrome or dysphonia. You will look for the head impulse test, the Halmagi test, and we'll see whether this one is normal. If it's normal, it's more likely to be a stroke. You look for central type of nystagmus. We'll talk about that. And you look for skew deviation. So these additional signs here are also called the hints sign, head impulse, nystagmus, and test of skew. And even if only one of those is pathological, that is not in the sense of stroke, of a peripheral disease, then you will consider it's stroke. And we'll discuss this in a minute. Now, a few things that are not helpful on your history taking are the following. So whether the vertigo is positional or not positional doesn't help much at all, because even cerebellar strokes are often positional. Whether the duration is short, well, you know, TIAs are short by definition, or whether it's long doesn't help you much either. And whether it's a rotatory, linear, or a dizziness kind of vertigo doesn't help you much on history taking either. So here is the famous head thrust test or Halmagyi test. And we have on the left side a physiological one. You ask the patient to look in your eyes, you hold his head, and you do a very rapid, but not very wide, head turning to the right and to the left. And you always ask the patient to fix your eyes. If the test is normal, then it looks like that. On the left here, you can see the patient is turning the head to the right and to the left. And at any time, he can fixate your eyes. His eyes are always on your eyes. Now here on the left side, you have a patient who has a normal one to the right, but now you will see he is having a little saccade at the end. I'll do it again when we turn his head to the left. So here it's normal if he looks to the right, but if we turn the head to the left, his eyes first go with the head to the left, and then he has to catch up with his saccade. So the patient here on the left actually has a peripheral left 8 nerve disease. And this is, of course, not stroke, it's peripheral. So if the Halmagyi test is pathological, it means it's peripheral and it's not stroke. So here is a patient where we can see she will first turn her head to the left, and you will see when we turn her head to the left rapidly, she will just have a little saccade to catch up with the examiner. Let's have a look now. You could see maybe the right eye doing a little catch up. Now again, you see there is a little saccade when we turn her head to the left, but not to the right. So she has a peripheral left 8 nerve damage. It's not stroke. The next question, if you have nystagmus on exam, is it due to stroke? And as you probably know, there are a central type nystagmus, such as the nystagmus that changes the direction. So if you look to the left, the nystagmus goes to the left. If you look up, it goes up. If you look to the right, it goes to the right, and so on. Whenever a nystagmus is vertical, either upward or downward, it's considered central. If it's dissociated, one eye does something else than the other eye, it's considered central. Or if you have a lot of nystagmus, but the patient doesn't really have any more vertigo or nausea, then it's rather central as well. It's not useful if you have the following situation. Again, whether the nystagmus is of short duration, provoked, or spontaneous, or long duration, that doesn't help you. If the nystagmus is conjugate and horizontal, or conjugate and rotatory, this can be central or peripheral. And whether the nystagmus is, again, triggered by a position is not helpful, except if you do the so-called Dix-Hallpike maneuvers, which we will not show today, which is characteristic for benign positional vertigo. Here is an example of a nystagmus, and you will see it's a central type nystagmus. So this patient, as you see with his right eye, he has a nystagmus, but not with the left eye. And I'll do it again. His right eye, he looks to the right, he has a nystagmus, but not the left eye. So this is a dissociated nystagmus. One eye is doing something else in terms of nystagmus than the other. And of course, many of you know that this is a internuclear ophthalmoplegia on the left, because not only does the patient have a nystagmus with the AB deduction of the right eye, but he also has a deficit on AD deduction of the left eye. So a typical central type nystagmus, so we think of stroke. Now here we come to specific oculomotor problems that are characteristic for the brainstem. And the first one we have already discussed, which is nystagmus. So this is already discussed in the previous slides. And we get to the other ones: Skew deviation, Diplopia, gaze paralysis, and then finally Ptosis and Horner syndrome. When we get to the skew deviation here, the way to discover a mild skew deviation is by the so-called alternate cover test. This is a patient who feels dizzy, who may or may not have vertical diplopia, and then you have to figure out what's happening with her eyes, and you do the cover and alternate cover test, which is, as you can see on the video, you cover first one eye while you ask her to look at you, to fixate your nose or your eyes. Now we cover the other one, and each time you see a little correction. The eye goes down, this eye goes up, this eye goes down, this eye goes up, this eye goes down. So this will tell you that actually these two eyes are not aligned, and that actually the right eye is depressed towards the lower part, and the left eye is a little bit elevated. So these eyes are having a skew deviation, which is a vertical strabism. So again, here this lady has the right eye, which is slightly depressed, and the left eye, which is slightly elevated, and she does this corrective saccades each time you cover the other eye. Now, what does this mean in terms of localization in the brainstem? It is a brainstem problem, and it means basically if you have the brainstem here with the midbrain, the pons, and the medulla, you draw this oblique line just in the direction of the depressed and the elevated eye. You draw the same line through the middle of the pons, and it means that your lesion that you're looking for in the brainstem is either above the oblique line on this side, where the oblique line goes to the higher end, or below this level mid-pons on the opposite side, where the oblique line points towards the bottom. Let's look at an example. This is an elderly man with acute vertigo and mild diplopia. This eye is about in a normal position, but this eye, as you can see, is slightly depressed. And if you do the alternate cover test, you will exactly see that this eye is depressed and this eye is elevated. So again, this is elevated. Let's draw our line from the higher eye to the lower eye. Let's draw this across the mid-pons. So this patient's lesion is either above this part of the oblique line or here below. And in fact, if you do the MRI, you can see here a midbrain lesion. So this lesion is up here and explains this skew deviation of this elderly patient. Now we get to vertical diplopia. We already said that it can be due to skew deviation, and we have just explained how to diagnose it and to localize it. However, it may also be due to brainstem stroke affecting the fascicle of the third nerve, which of course is responsible of elevating or lowering the eye. So midbrain stroke in the dorsal part can cause you vertical diplopia, also because the fascicle of the third nerve is paralyzed. If we talk about gaze paralysis on the vertical level, then the stroke is basically due to a uni, but most likely a bilateral lesion of the midbrain, which usually also involves the lower thalamus. Let me show you an example. And again, there are several combinations, but the essentials are that up and or down gaze paralysis are caused by this midbrain lesion involving usually also the thalamus. This is a patient 5 years after his stroke, and he comes to our outpatient clinic. He's doing well. He moves his hand, no ataxia, no speech problems. But if you look at the eye mobility, we can see on a horizontal level, everything goes fine to the right and to the left. But on a vertical level now, I asked him to look up, and he just cannot look up at all. So it's a gaze paralysis upward, and also he cannot look down, a gaze paralysis downward as well. So a complete vertical gaze paralysis. And this was his stroke in the midbrain, and also affecting the thalamus, the lower thalamus on both sides, which is quite severe and which explains why he cannot move his eyes neither upwards or downwards. Now we're getting to horizontal diplopias, and here you have several possibilities why in the brainstem you can have horizontal diplopia. You can have a lesion of the sixth nerve, that is that affects the fascicular part within the brainstem of the sixth nerve, which is of course located in the pons. This patient cannot look to the right with her right eye, so she has a paralysis of a B deduction of her right eye. The left eye works fine. Now you can also have a pseudo-6 nerve palsy or a hyperconvergence, which is often seen in the midbrain dorsal area with strokes. And finally, you may have a problem with AD deduction with brainstem strokes, and this is usually due to internuclear ophthalmoplegia. And as you know, this can affect either the pons or the midbrain, the median longitudinal fascicle. So here, as you can see, horizontal diplopia is essentially due to strokes in the brainstem, either in the pons or in the midbrain, and rather in the dorsal posterior part. Another word on conjugate horizontal eye deviation, which doesn't cause diplopia because both eyes don't move well either to the left or to the right. So if you have a patient like this one with a stroke who looks with both eyes to the left, a conjugate left eye deviation, where is his lesion? Well, you know that most often a patient with both eyes looking to one side, he looks at his stroke. He looks at his lesion here in the hemisphere because this is the most frequent stroke localization. Now, what can happen is that the patient has a stroke in the midbrain or in the pons. And here, interestingly, it's the opposite. So if both eyes look to the left, the stroke in the midbrain or in the pons is on the right side. So actually, we call this the wrong way eye deviation. That is, this patient here, for example, has a right pons stroke. That means he has a left hemiparesis. And instead of looking away from his hemiparesis, he looks at his hemiparesis. So his both eyes look to the left and his hemiparesis will be on the left as well. And if we get a little further down to the Wallenberg syndrome in the medulla, things turn around again the other way. So a left Wallenberg syndrome, for example, will again have an eye deviation to the left with both eyes, but then usually this patient will also have fast saccades to the right and nystagmus fast beating to the right and slow eye deviation to the left. So you can see it is interesting. And of course, to localize finally a stroke, eye deviation alone is not sufficient. Of course, you will always look then for other symptoms that explain the eye deviation, either as being hemispheric, brainstem, or lower brainstem in the medulla. Here we get to the ptosis, which can be unilateral or bilateral. Of course, if you have a ptosis and a suspicion of stroke, this is usually in the posterior circulation, that is in the brainstem. If you have a ptosis like this person with a Horner syndrome and a meiosis, then you know it is a Horner syndrome. And if you have usually contralateral long tract signs, then the stroke can be anywhere ipsilateral to the Horner syndrome in the brainstem. So Horner's on the right can be anywhere caused by any stroke in between here, the hypothalamus and the thoracic nerves. So anywhere in the brainstem on the same side as the Horner syndrome. The hemiparesis would be on the other. Now you may also get a Horner syndrome with meiosis and then contralateral long tract sign in a carotid dissection as here. But then hopefully you will also have some hemispheric stroke signs. So this patient will hopefully have, for example, if he has Horner's on the right, from a right carotid dissection, he would have hemi-neglect on the left. And then you know it's not in the brainstem, but you know it is in the hemisphere, and the Horner's is not due to the stroke itself, but due to the dissection. Finally, if you get unilateral ptosis in stroke, it could be not a Horner syndrome, but it could be a patient with a central lesion of the third nerve or the fascicle of the third nerve with a mydriasis here. The pupil is dilated, so the opposite of the Horner syndrome, often a quite severe ptosis. The eye is often completely closed, and again, contralateral long tract sign. So here again, the stroke would be ipsilateral of the third nerve palsy somewhere in the midbrain. So these are the unilateral ptosis localization possibilities in acute stroke. If your ptosis is bilateral, like in this patient who cannot open her eyes, even if you ask her to, there are essentially two possibilities. One is again the brainstem. So it's again the nucleus of the third nerve, which can be unilateral even, because actually the elevation of the pulp of the eyelids are actually innervated from both sides. So even a unilateral third nerve palsy can cause bilateral ptosis in a midbrain stroke. And this patient can very well be awake, but cannot open her eyes. Now, the other one would be not a brainstem stroke, but a large right hemispheric stroke, which causes, as you probably know, the eye-opening apraxia, so an inability of the patient to follow the command of opening his or her eyes, despite the fact that the patient is awake, but he cannot follow these commands because the right hemisphere seems to be coordinating this kind of eyelid movements. Now we get to the decreased level of consciousness, which is also quite characteristic for posterior circulation strokes and brainstem strokes. Here we have this lesion location, which you probably know, that is in the midbrain plus minus the thalamus. These are the centers of the reticular activating system. Usually, in order to have decreased level of consciousness with these kind of strokes, you need a bilateral stroke, as it is typical in an embolus that goes to the top of the basilar artery. Sometimes this is very transitory, so the patient actually has an acute coma and the clot dissolves spontaneously and he wakes up only with eye motor problems, but often you will still see the clot in the top of the basilar on imaging. Now, of course, anterior circulation strokes, if they are very large or if they are multiple, they can also cause decreased level of consciousness. And of course, large hemorrhages, both supratentorially and in the posterior fossa, due to the mass effect, can cause decreased level of consciousness. There are two things to remember. Not every patient who does seem to be in coma is in coma. So we have these pseudo-stupor or pseudo-coma situations in posterior strokes. If a patient has mid-basilar occlusion, he may have a locked-in syndrome. He's paralyzed anywhere in the face, in the extremities, cannot talk, cannot move, but his consciousness or her consciousness may be still preserved. Or remember, if you have the bilateral ptosis from a small midbrain lesion affecting the third nerve nucleus that we have discussed before, this patient may have bilateral ptosis and is still very awake, just he cannot move his eyelids and open them. Another issue with decreased level of consciousness, unfortunately, that these strokes are often missed. As you can see in this analysis here, you have in the blue, with the blue line, you have the patient's NHSS distribution with correctly diagnosed strokes in the ER, and the red ones are the patients who are missed. So the red ones have a slightly lower NHSS in the ER, but except for this little second peak, you can see the missed strokes, they have also very severe NHSSs. So why is this the case? Why would these be missed? Well, because if you have an acute stupor or coma, you come in with a very high NHSS. And these, of course, are typically basilar artery occlusions, which are often missed because loss of consciousness is not frequent in acute ischemic stroke. Because it is atypical, we miss them. We think it's a toxic coma or it's status epilepticus or an encephalitis, where in fact it's a brainstem stroke. So beware of missing patients with acute severe stroke due to acutely decreased level of consciousness, because this, of course, is a very good opportunity to do acute revascularization therapy. Finally, we get to the bilateral crossed manifestations. As you know, it is characteristic for brainstem strokes to have bilateral manifestations. And the reason for that is, of course, that the basilar artery gives rise to both branches to the right and to the left in the brainstem. This is a cut across the brainstem with the paramedian arteries on both sides, the short circumferential arteries in yellow, the long circumferential arteries in red, and then the cerebellar arteries going up into the dorsal part of the brainstem and the cerebellum. And the basilar artery with a clot in it can, of course, then give ischemia to both sides of the brainstem. In addition, you have sometimes crossing of fibers like cerebellar fibers to the right, to the left. And so a stroke on the right can also give you hemiataxia on the opposite side. And so this means that basically you can have bilateral corticospinal signs, bilateral ataxia, bilateral hemisyndrome of a sensitive nature or a combination. And if it's bilateral, then you immediately think of brainstem strokes. Of course, you may also think of spinal cord lesions at some point. A special form of bilateral manifestations is the crossed manifestation of stroke, or the syndrome alterne, which is again typical pathognomonic for posterior fossa strokes. If you remember the anatomy of the corticospinal tract, for example, going through the internal capsule down through the whole brainstem here, then crossing at the level of the pyramid into the spinal cord to the opposite side. And as this corticospinal tract goes down, it gives rise to input on the other side, but it goes just underneath or beside the cranial nerves on each level of the brainstem. Now, if you have a stroke, for example, here in the middle of the brainstem, in the pons, what do you get? You get on the same side as the stroke, you get a paralysis of the seventh nerve. So you get a facial paralysis with a deficit on the same side as the stroke. And actually this deficit often looks like a peripheral kind of facial paralysis. But then because you also hit the corticospinal tract here that crosses over, you will get on the other side the long tract signs, that is sensory ataxic or paretic symptoms on the opposite side. So you have on one side cranial nerve deficits, on the other side long tract deficits, and this is called the crossed manifestation. If you have, for example, this patient, he has deficits in the left side of the face on a sensory level, and on the right side on the body level, that would be, for example, in a Wallenberg syndrome. Here we can look at a patient with a typical example of such a crossed brainstem stroke, an elderly patient. As you can see, he has on the right side a facial paralysis. He can barely close his eyes. His wrinkles on the forehead are not well developed on the right side. They are paralyzed. Also, if you ask him to show his teeth or move his cheeks or so, you can see he has a clear paralysis of the whole side of the right face, a peripheral kind of paralysis. He can look to the left, he cannot look to the right. He has a gaze paralysis to the right, so there's a little bit of a gaze deviation to the left. Finally, we also ask him about the sensibility of his face. There he says, no, I'm okay, I feel well on both sides. Now let's have a look at the long tracts. Let's have a look at his extremities, whether he has a paralysis on the right or on the left. Here he seems to move his left body well, but you can see he moves his right body even better. So actually he has a drift, a partial paralysis of the left arm. So the hemiparalysis is on the opposite side as the facial paralysis. So in summary, this patient has a right facial paralysis. He has a left hemiparalysis. He also has the gaze paralysis. You're looking at his left hemiparalysis. Both eyes look rather to the left. So this is a typical crossed syndrome in a pons stroke. We call this the Foville syndrome. And Professor Yong Kim will tell you more about these specific syndromes in a minute. So to finish up, here are the take-home messages, the general features of posterior fossa strokes, and I hope you don't have too much vertigo by now by all the details I've told you. Number one, the red flags for acute vertigo. Remember that a patient who cannot walk anymore, a patient who has sudden onset of unexplained vertigo has to be considered as a stroke. We have these specific oculomotor problems such as skew deviation, vertical or horizontal diplopia with central findings, which are typical of brainstem strokes. an acute decrease of the consciousness in the top of the basilar strokes and the bilateral cross manifestations, which are pathognomonic for brainstem strokes. And a few other features of brainstem stroke. So don't forget that essentially the stroke mechanisms, both hemorrhagic and ischemic, are essentially the same for anterior and posterior circulation strokes, cardioembolic, atherosclerotic. Maybe in the posterior fossa you have a bit more lacunous strokes because the fibers are so densely packed that even small lacunes will become clinically manifest, which is not necessarily the case in the larger anterior circulation. These strokes have a higher risk of being missed. We call these stroke chameleons. They are strokes, but we don't recognize them as strokes because they look like an acute peripheral type of vertigo, or they look like acute coma of another origin, but in fact, these are stroke and these should be recognized quickly because time is brain also for the posterior circulation. The faster you recognize and treat, the better and brighter the future of your patient will be. This is what I wanted to discuss with you. So I will hand over to Professor Young Kim for the specific brainstem and cerebellar stroke syndromes, and then we will take questions and answers. Thank you very much.